little bit modification of this, which is a microcatheter guided parallel wire technique, or a double lumen catheter guided parallel wire technique, and then the IVUS guided technique also comes into play to facilitate your antegrade wiring of the CTO. Now, why do you choose loose tissue tracking? If you see, the microcanals are seen in most of the mature chronic total occlusion, as shown in the histopathological studies, and the continuity of macrochannel is observed in about 85% of the CTO length. Now, many times you don't see macrochannels on coronary angiogram, on non-selective coronary angiogram. Still, there may be these macrochannels are present, and you don't really know unless you try and go through one of these macrochannels. In CTOs, loose tissue segment was observed continuously in proximal to distal segment, and you can take advantage of this macrochannel tracking to get into the distal vessel. Now, in terms of wiring, which wire to choose, when to choose this wire, it all depends on detailed assessment of the cine angiogram. As I said, macrochannels can be visibly angiographically in 30 to 50% of the cases, but not always they are visible. If you can see the microchannels, they are visible, and you want to do antegrade wire escalation, usually the choice of wires are some kind of a plastic jacket or hydrophilic wire, such as Fielder XT, XTA, Fielder FC Pilot 50, or Terumo run-through type of wires can be helpful. If the segment is very, very fibrocalcific, then extra support wires are needed. The wires, I would say here, are Gaia series of wire, 1, 2, 3, and Next. Gaia Next is really an advantage in this setting, and then Miracle series of wire, Crosset series of wire, intermediate wires, and Conquest Pro 8 and 12 grams. So if you see, I will just touch base with you simply about what the parallel wire technique means. It is effective when your first wire goes into a subintimal space and makes a false lumen. Now, there is a tendency that people and operator will try to get this wire out of the subintimal space and then try to achieve a true lumen. And it is sometimes very difficult, because it's very difficult to go into a different plane if the first wire is taken out. The second thing, it could be that you use the subintimal space and go subintimally, knuckle the wire down and use the crossboss and AWE equipment and try to get the recanalization done in that way. But another alternative is to use a parallel wire, where if your first wire is in the subintimal space, you leave that wire there and try to use a second wire guided by the first wire to get into the true lumen. And obviously, I will show you 1 or 2 cases to demonstrate this technique a little bit more. So this is how the parallel wire works. You take the second wire, put a little sharper curve and maybe a little bit stiffer wire, and try to get into the distal true lumen. Now, when we talk about more recently, people have started doing this technique with macrocatheter supported, mainly with Crusade or Sasuke or whatever double lumen catheter you have got. And this table here shows you that compared to single lumen catheter and double lumen catheter, you can increase the pushing force by about 3 to 4 times for the second wire to gain entry into the true lumen. So this has really improved your success rate here with parallel wire. Obviously, the Gaia series of wire have also helped in antegrade wire escalation, because these Gaia wires have got one-to-one torque transmission, as you can see, and you can easily manipulate these wires into the CTO segment, and by step, you can manipulate it better into the distal vessel. And this is the Gaia Next is an advancement to the Gaia series of wire, which are now freely available. Gaia first, second, and third, they are available, as you can see here. If you can see this here, what this thing shows here in terms of movement of the wire into the tissue, loose tissue, Gaia Next, and the Asahi Conquest series of wire. And if I just show you here how these, this is really changed with the Gaia series of wire, because they've got a short company-made tip. It could be easily manipulated in the CTO segment. You can pull the wire and you can redirect this wire into the intimal tissue and try to keep the wire intimal. As you can see here, you can easily move this wire and the real difference is, if you see the blunt tip for Miracle tip and the micro cone tip for the Gaia Next series of wires. So it is easily maneuverable and you can manipulate this wire easily. So it's all about your philosophy as well, and the intention when you start the case after assessing the coronary angiogram in more detail. because if you are going to go for integrated wire escalation, you will take all efforts to keep the wire in the intimal tissue. And if you want to go subintimal, you can easily, there are techniques which you can achieve as well, and then that philosophy is slightly different. So if I just share with you some case, this is just a simple demonstration. You can use some adjunct techniques like balloon side branch, balloon anchoring to increase the backup support in both parallel wiring and your integrated wire escalation. So I will share with you some simple cases to demonstrate my point. So this is the right coronary artery coronary total occlusion. Here you can see it's a fairly standard kind of occlusion. It's got a it's like a well-defined proximal cap. There's a side branch at the proximal cap, and then you can see there's a macro channel which is very tortuous, and the distal landing zone is pretty good, and the length is around 20 millimeter, a little bit longer, a little bit shorter. Now, if you go down several algorithms, Asia Pacific or hybrid algorithms, obviously you will start with integrated wire escalation here. It all depends how the integrated wiring will happen here. So this is a 7 French guide catheter AL1. You can see the distal vessel clearly. So what I did is we started with a fine cross here and a Fielder XTA. Now you have to have a confidence in your mind whether you want to go do integrated wire escalation, how long you're going to try, and what you will do if this doesn't work. So if you see here, this wire here. Now, obviously this wire is not making much progress, but it seems to have entered the macro channel. So I think what you have to do, you have to have a perseverance here, and you have to persist with this technique. So we persisted, and you see here, step by step, this is a Fielder XTA, and slowly it is making progress into the macro channel, and it's going in. And obviously, the thing is that you require some patience at this point of time to maneuver your wire. If you use some wire like Pilot 50, 150, 150 at this point, it's more likely, I would say, that that will not travel the macro channel and maybe go subintimally, and then you have to adopt some subintimal technique. So my point here is that you have to have in your mind, after looking at the angiogram, what technique you are going to use, how long you are going to persevere with it, and if it's not working, what's your backup technique. So I persevere with it, and then you can see that the wire is making some progress after manipulation. It entered the distal vessel, and we were able to do this procedure. Obviously, there was some problem in balloon crossing. We have to do some plaque modification, rotablation after the balloon failed to cross here. And then this was the final result. In the interest of time, I've just gone to. So this demonstrates that you can achieve integrated wiring with a macro channel here. This is another case. If you see here, this was the second attempt. One of my colleagues did this case. And this is an ambiguous proximal cap with a large side branch at the proximal cap. And the distal vessel is filling from collateral channels. And there's a diagonal branch at the distal vessel as well with minimal disease. So it's not a very long CTO here. So you see there are some interventional collaterals present here as well. And obviously there's a good landing zone. But clearly the proximal cap is ambiguous. So the failure point was the subintimal location of the wire integrate. So what I decided to do here is, obviously, if you go down the track of integrated wire escalation, you can wire the diagonal branch. So I took use of intravascular ultrasound into the side branch to really check my proximal cap entry into the CTO segment. That's the area. If you can see here, there are two areas of interest at the proximal cap here. One goes down in the septal, and one is a little bit higher up. So it's not clear which channel you have to enter. So you can take advantage of intravascular ultrasound. This is the lumen. And the second picture you see here, so what I did is I took a Gaia with a microcatheter and tried to enter in one of these caps here in the proximal segment. And on the right-hand side, you can see the IVUS demonstrates you from the side branch that the wire is in the center of this lumen. So I was confident that wire has entered into true lumen. So that's what the IVUS is going to tell you. And then I made progress with it. I entered it. So I think the failure point was in the first attempt was that the wire entered subintimally. And then we obviously, in the interest of time, we just went with the Gaia second wire and recanalized this vessel well, as you can see here. Now, this is another case you see here. This is a proximal RCO CTO. If I just go to the previous picture. So this is like an ambiguous cap, short segment, distal vessel has got disease, and obviously this is a retrograde picture here. So there are possible options here. You can do antigrade wiring, you can do parallel wiring, you can go retrograde approach. You can also use easily use the subintimal techniques here if the antigrade wiring doesn't work. But so what we decided, what we did here is obviously the Gaia 2 was used, supported by fine cross. As you can clearly see, this is in subintimal plane. Now, obviously, the basic rule here is that in terms of, so obviously we were trying to go parallel wire here because the antigrade wire was not very far away from the true lumen, and the CTO segment is not very long. So we tried to go parallel wire, and the concept of parallel wire is you try to choose your second wire based on the behavior of the first wire. If the first wire went easily, then you use more or less similar or a little bit higher strength. And if it was difficult with the first wire to achieve the subintimal space, you use a little bit higher strength. But usually people will go, if the first wire is Gaia 2, you will go with Gaia 3 or CP12. So do not force the wire to knuckle. Now that is the philosophy which comes into play here. If you want to try the parallel wire in real sense, you have to give a 10 or 15 minutes and not start knuckling the wire and use the subintimal space. So I will leave the pilot 200 on the shelf at this point of time and go with some other wires. We went with Gaia 3, which again went subintimal, but eventually with double lumen, we were able to get the true lumen with Hornet 14 wire, as you can see here, and we were able to get the distal wire into the true lumen. So the point to make here is that the parallel wire is not really a re-entry technique. So you try to achieve a true lumen from proximal cap into the CTO body, into the distal lumen. And then this was the final result here. So I'll skip this. Obviously, pressure wire technique, wire manipulation is the basic skill of an interventional cardiologist. To manipulate a second wire, we need to learn this. And sometimes it's very easy. In 10 to 15 minutes, you can get this parallel wire and can avoid all the misery later on. This is another right coronary artery CTO, second attempt case. If you can see here, first attempt we failed. So I went with a ADR actually. So I thought this is a quite ambiguous proximal cap, little bit long segment, good distal landing zone. So I started with crossboss here. If you see on the left or right panel, I took the crossboss, and in no time I was able to get the crossboss into the side branch here. Now the problem with I faced is that I was not able to get this crossboss into the distal true lumen beyond the branch here. So I tried for a little while. I was not able to. I think there was a subintimal segment up to the distal cap. I was not able to get into the distal true lumen. So what I did after a prolonged attempt, or maybe I was not that skilled to get it from the side branch into a distal vessel. So I went back to my antigrade wiring skills, and I used a double lumen catheter here. So I put the double lumen catheter on this wire, as you can see here, and then use the second wire, which was Fielder XT. In this case, I was very lucky to get the true lumen with Fielder XT and with several manipulation and in multiple view orientation. I was able to get this wire into a distal true lumen, as you can see here, and I was able to achieve recanalization by my second wire, which was used with double lumen catheter, and this is the final result here. So I think antigrade wire escalation or antigrade wiring can be adjuvant to your other techniques. This is a LAD CTO, you can see here. A very complex CTO actually. It's a flush occlusion at a large branch with the diagonal heavily calcified. So you will be surprised sometimes what the antigrade wiring will do for you here. And the distal vessel is severely diseased here. So there's not a really option for antigrade subintimal, and the retrograde channels were not very good. So I used the fine cross with Fielder XT. And to my surprise, you will see here that the Fielder XT actually crossed this lesion into the distal LAD. See this here on the left-hand panel, it was buckling a little bit. Then I advanced, I entered the CTO segment, and calcium was helpful in multiplanar views to see that the wire is in the middle of the calcium. And then I was able to go further down, as you see here, into the distal vessel after some negotiation. And then there was some problems in obviously getting the balloon down. I have to do a rotational atherectomy here first, and then this was a balloon non-dilatable lesion. So point to make here is that you can sometime in a very complex looking CTO will be able to get through antegrade wire escalation. So we have to do some rotational atherectomy, and after DK crush and 3 stents, this was the final result in the LAD CTO to secure that side branch as well. So in my conclusion, what I would say is that majority of the CTO could be successfully recanalized by antegrade wire escalation and other supportive techniques such as parallel wire, intravascular IVUS guidance to gain entry into the proximal cap. What I have not shown you here is sometimes you can get subintimal to true lumen by IVUS guidance as well, but that's a very complex technique and it's not easily teachable, and I think the outcomes are not very good. Now, new guide wires, particularly Gaia series of wires, really changed the landscape for antegrade wire escalation with increased success rate because you can manipulate and move these wires with fairly good control, torque transmission, and maneuvering in the CTO segment. These techniques are teachable with predictable outcomes. Subintimal techniques should be reserved for experienced operators and bail out. In my clinical practice, we use some subintimal wiring techniques as well. And the success rate are high and comparable with good procedural success in antegrade wire escalation. Now, I will stop here. I've got a few more slides for rebuttal. I will discuss with you at the end for like a couple of minutes after Arun's talk. I think that will make more sense to keep these slides on hold for the time being. So I'll stop here, guys, and if there are any questions, we can take it at the end. And I'll hand it over to the organizers to take this proceeding forward now.
Thank you, Dr. Sudhir. I think that was a very brilliant talk. A lot of examples and a lot of clear strategies on antegrade wire escalation that were discussed. We'll probably answer the doubts and some clarifications at the end of the talk by Dr. Arun. Shall we ask Dr. Arun to start with this talk on ADR?
So first of all, yeah, can you guys see my slide?
Yeah, we can see a slide, excellent.
Right. So, I mean, first of all, thank you, organizers. Thank you, Dr. Verma, Dr. Shivakumar, and I mean, honestly, thank you, Sudhir. I mean, it's kind of short notice, really appreciate it. By the way, disclaimer, I got to tell you, Dr. Sudhir Rathore and I mean, he's like a really good buddy of mine. So I think for the most part, yes, we are supposed to debate, but we got to find reasons to debate because I think pretty much there's consensus on what, on a lot of the stuff that's being said. So I'm going to start with that disclaimer. So really, just to clarify the position, he's supposed to talk on is wiring a better option, and I'm supposed to talk on is dissection and reentry a better option. So we will kind of try to stick to the format here, but I would love to kind of hear various points. I mean, the first thing that I do want to say is that, flow distal to the CTO, typically, I mean, if you're really going after a juicy one, it's kind of TIMI3, all those via collaterals. We all agree that we want to preserve side branches. We want outflow vessel patency in order to improve your, the distal bed perfusion. And just achieving TIMI3 flow is not success. And we also, I think, for the most part, know today, and I'll kind of support some of this with data, that whether it's antegrade or retrograde, dissection reentry does not necessarily result in subintimal tracking, and wire-based procedure does not always result in interflock tracking. So just to give you a little bit of a historical perspective, this data from Japan, and this is actually from almost 9 years ago from Tsuchikani Sensei, where they did look at data from the Japanese Proctor, the J. Proctor registry. Very, very revealing. This was actually presented in the Retrograde Summit. And the questions they asked were, how often do you subintimally track in contemporary CTO PCI? Is there a problem? Like, what if you do go subintimal? Does it affect your long-term outcomes after drug-eluting stents? And going back even further, I mean, this is actually published from Cleveland Clinic, actually as the initial cross-bus data from 2011, if memory serves right. And they really wanted to see what they could glean from IVUS data, etc. What did they actually study? 26 CTO lesions, forward retrograde, subintimal tracking in almost 50%. It was more often in reattempts, typically longer stents, longer procedure times, fluoroscopy time was longer, and contrast dose was longer, and they had no long-term data. So I guess it was published in CCI in 2012. And here again, they were trying to like get more data from IVUS on retrograde versus antegrade when you're going after CTOP for CTOPCI. And this again was this is 2009 publication, so 48 CTO lesions. And again, as you can see, this is a disproportionate number compared to most of the Indian CTO operators. A lot of retrograde, subintimal tracking, more in retrograde. Once again, no long-term data. This was kind of the basis for which Dr. Chichkani wanted to study how there might be differences in outcomes. So what they did was to really wanted to see antegrade, how does it go, retrograde, how does it go. They wanted to check and see with IVUS about whether they were truly intraplaque or they were subintimal, and then they wanted to get follow-up angiograms and 12-month clinical follow-ups. And these were the primary endpoints that they were looking at. So in the interest of time, I'm just going to go to the results. Just again, from a textbook standpoint, intraplaque is when you're within the plaque. Subintimal is when you're subintimal. Here between 3 to 6, you kind of see the true lumen compressed. Okay. I'm just going to go to the results of this particular study. So if you notice, retrogrades typically took longer time, obviously longer fluoroscopic time. Procedural success, I mean, they pretty much nailed it every time. I mean, this was even going back 9 years. Perforations, perhaps a tad bit more in retrograde. And, there was no in-hospital MACE, which is interesting. How did they actually achieve success? Mostly through reverse cart. Retrograde wire cross was about a third. Kissing wire technique, 8.7, and very rarely do they use cart. In the interest of time, I'm not going into the details of each of these. If you go antegrade, very low incidence of subintimal tracking. Retrograde is almost twice the incidence of subintimal tracking. What did they finally show? I'll just go here because that's what we really want. Does this affect long-term outcomes? Hardly ever, right? Cardiac death 0-0, MACE 14 versus 4. But look at the real hard outcomes. Subacute stent thrombosis 0-0. There's one non-cardiac death apparently by a car accident. So what did the results show? Let me just get here, the summary, right? Subintimal tracking was more in retrograde than antegrade. Lesion characteristics, obviously in the subintimal tracking group were harder. That's why they had to go retrograde. There were no significant differences in 1-year TBR. QCA identified longer occlusion and stent lengths in the subintimal tracking group, obviously, because that's why they had to go subintimal, or they ended up going subintimal. Their conclusion was there was no clinical negative impact with, at that time, state-of-the-art drug-eluting stents after subintimal